Aloha and welcome to our series about nursing skills. We're going to spend some time during this series talking about different nursing skills and the theory that kind of underpins why we do what we do and what it is that we're doing, the meaning of all of the data that we're collecting. And so today we're going to talk about vital signs. And from the statement alone, we can tell that vital signs are vital, and that means that they are necessary for life. However, you will notice that sometimes we include something known as the fifth vital sign, which is not actually vital, but I'll explain to you the reason why we talk about the fifth. So vital signs, as we know them in nursing, are our heart rate. This can also be measured in terms of our peripheral pulses, and we'll differentiate between those two. Our respirations, our blood pressure, measuring temperature, and you will hear pain referred to as the fifth vital sign. So I don't know about you, but I'm here to tell you that heart rate, respirations, blood pressure, and temperature are very vital. These need to stay within a balance. The other word that we use for balance is homeostatic, right? So we need our heart rate, respirations, blood pressure, and temperature to fall within the normal range in order to know that our patient is okay. Pain is referred to as the fifth vital sign because we want to be monitoring pain on a regular basis. So we add it in there as the fifth vital sign so that we remember to ask our patient whether or not they're having pain, okay? We want to memorize the normal ranges for adults. There aren't a lot of things that I require rote memorization for because many of the things that we learn in nursing we can look up. However, vital signs are vital for life, and so we must memorize the normal ranges. So for heart rate, this is going to be 60 to 100 beats per minute will be considered the normal range. Our respiratory rate, normal range will be considered 12 to 20 respirations per minute. For blood pressure, we're going to talk in a lot more detail about blood pressure, but we'll just say that a normal blood pressure for an adult is around 120 over 80. And a range for temperature is about 98.6 to 100.4. And so what that means is if we have a temperature that's over 100.4, in many cases, we refer to that as a fever, all right? So over 100.4 is really considered a fever. In the older adult, they tend to have a lower body temperature. So in the older adult, the range for a normal temperature is going to be about 95.9 to 99.5. And so those are going to be some important normal ranges for you to know. So when do we measure our patients' vital signs? Well, sometimes in the hospital setting and in other settings, we can actually have orders for how frequently to monitor the vital signs. Sometimes we will monitor them every shift. A physician could have us monitor vital signs every 4 hours. If we were doing a certain procedure, we might measure vital signs before the procedure and measure vital signs after the procedure. But anytime there's a change in condition, the nurse will want to get a full set of vital signs. If the patient says they're not feeling well, anything happens out of the unusual, right? If a patient has a fall, then we want to go ahead and measure the vital signs. There are some medications that we give to our patients that require us to check their blood pressure and their pulse prior to giving these drugs. And a good example of that is metoprolol. It is a blood pressure medication that also can lower the heart rate. So before we give metoprolol, we always measure the blood pressure and the heart rate. And generally speaking, if the heart rate is below 60, we hold the metoprolol and we let the physician know that we did not give that drug due to the fact that the heart rate was less than 60 beats per minute. Oxygen saturation is another vital sign that is not really generally listed with the vital signs, but it is one that we do measure most oftentimes when we're doing a full set of vitals. And this is checking the arterial oxygen saturation. And we do this by attaching a probe to a patient's finger. And we're measuring the amount of oxygen that's bound to the hemoglobin molecules. 95 to 100% is really considered a normal range for oxygen saturation. This is in a healthy individual. If you ever check a pulse oximeter or oxygen saturation and the reading is less than 70, you don't have a reliable reading. And so at that point, you really need to be looking at your patient, right? Because even though we're measuring vital signs and we use machines to measure things, it's always important to look at our patient and talk to our patient, communicate with them as well. And so pink is good and blue is bad. So in other words, measuring vital signs is always going to be extremely important, especially when a patient is having difficulty. One of the first things that the physician is going to ask you when you call to report about any problem with a patient is, what are their vital signs? And so skin color is important. Looking at the patient, communicating with the patient, is important. Knowing that they're awake, alert, and oriented, that they're not confused, especially acutely confused, meaning that they've been awake, alert, and oriented, and now you go in the room and their color is bad, they're looking a little dusky or cyanotic, and they're confused, and they're not answering questions. Certainly those are things that we are going to be reporting to the physician as well. So like we said before, pain is not actually vital. We can be in excruciating pain and still be, alive. But we do check pain rates on the average regularly with vitals, so we can make sure that we don't have patients laying there in pain. So in order to assess the pain, and we'll talk more about this, but I just want you to get an overall idea of how to measure pain. The standard for measuring pain is asking the patient to rate their pain on a 0 to 10 scale, with 0 being no pain at all, and 10 being the worst pain they have ever felt. So it's really important to let the patient know what 0 means and what 10 means, and then they can rate their pain anywhere from 0 all the way up to 10, okay? Sometimes our patients cannot speak to us, and for whatever reason, we can use a different type of pain scale. And this is an example here of the FACES pain rating scale, where you can see what a face on an individual looks like with no pain. A little pain, hurts a little more, even more. At 8, you can see that it's not a happy face, it's a frowny, sad face. And at 10, we've got the worst pain where the patient looks as though they're crying. So I wanted to take a second to talk about facial grimacing and what that means. You'll hear people say there was no facial grimacing, or that they did note facial grimacing. And what that means is you look like you're in pain, like this person does in this picture. The other thing that we see here is called guarding. So let's say we had some surgery on our abdomen, and we see a patient in the bed looking like this. They're grimacing, so they're looking like they're in pain, and they're also guarding. They've got their hands kind of over their abdomen in the place where they're having the pain, okay? So these are two terms, grimacing and guarding, that you will want to be familiar with. Let's talk about temperature, measuring temperature. We said that older adults have a lower normal or baseline temperature than adults. And a normal temperature may actually be elevated in an older adult, right? So we said that the range was for normal for older adults was a little bit different, all right? So here's the way this works. It's always important to know what the baseline vital signs are. So what do I mean by that? What's the baseline? The baseline is what they were on admission or what they are usually, okay? So for example, we might have someone whose blood pressure is usually about 120/80. That's their usual. And you go in, and today, after starting a new blood pressure medication on the patient, their blood pressure is 100/60, okay? So that's considerably lower than their baseline, okay? And of course, that's after we've given them some blood pressure medicine, but it is a change from their baseline. So we always want to know what the baseline is. And people will say to you, you might go to the physician and say, well, I'm concerned about this patient, their blood pressure is 160/100, and their pulse is 100. And the doctor might say, well, what's their baseline blood pressure and pulse? And you as the nurse will want to know what their baseline is. So, in measuring pulses, there are two different ways really that we do this. Well, actually two different ways that we measure a pulse. We measure peripheral pulses and we measure an apical pulse. So first I'm going to talk about peripheral pulses. Measuring the peripheral pulse, we will count for 1 minute, all right? So for example, if I was going to be measuring my radial pulse, I would be putting 2 fingers in this groove here right below my thumb, and I would be feeling the pulsation, and I would be counting how many pulsations I feel in 1 minute. When we measure peripheral pulses, we're measuring rate, rhythm, and strength. Rhythm is when we're describing whether it's regular or irregular. So regular is boom, 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 boom. If it's irregular, what you will feel when you're feeling for the pulse is you'll hear boom, boom, boom. So it will be regular, and then it'll be irregular for a period of time, and then you'll feel it kick back in to be regular. Okay, so if you and it's not unusual to identify an irregular rhythm. You just want to make sure that the physician is aware and that this is well documented in their chart. Strength of the pulse corresponds to the rhythmic pulsation. So rhythm is that regular boom, 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 right? But the pulsation that occurs in that regular rhythm, all right? And this is actually what we feel when we're feeling the pulse is that blood moving through the arteries, okay? So when the heart pumps and blood moves through the arteries and we're feeling for the pulse, we're actually feeling that rhythmic pulsation of that blood. And so if the blood volume in the body decreases, the pulse can be weak and difficult to palpate. We call it palpation, palpating the pulse. And so I'll give you an example. In the case where there's been a trauma and you have a patient that's bleeding out on the side of the road after a motor vehicle accident, you might go to check for a pulse and you might feel that the pulse is weak and it's hard to even find that pulse, and that's going to be due to blood loss. If we have an increase in blood volume, we may have a bounding pulse that's easier to palpate. Generally speaking, if someone is well hydrated, we can usually feel a pretty nice bounding solid pulse. If I go out and I run around the block 5 times and you check my pulse, it's going to be bounding as well. So we describe pulses as being absent, and that would be 0. Sometimes we describe it with numbers and words. If it's weak, it's going to usually be a +1. If it's diminished, it may be labeled as a +2. If it's strong, a +3, or abounding is +4. And a thready pulse is also a weak pulse, and it's barely palpable, okay? So we can barely find it. And it could be fast or slow, it's just that it's very, very weak pulse. So the areas of peripheral pulses on our body are listed on this picture. We have carotid pulses, we have our brachial pulses, we have our radial and ulnar pulses that are in our wrist. We have our femoral pulse that's in our groin. Our popliteal pulse is kind of behind our kneecap. And then the two on the lower extremity are the posterior tibial and the dorsalis pedis. And I will tell you that clinically, the 2 pulses that we measure the most that are peripheral are the radial pulse and the dorsalis pedis. And the dorsalis pedis pulse can be found on the top of the foot. And sometimes the dorsalis pedis can be difficult to palpate, and occasionally we have to use a Doppler or an ultrasound to locate the dorsalis pedis. If you have difficulty identifying the dorsalis pedis pulse in your patient, I encourage you to get your instructor or get another nurse to help you identify it, because it takes practice and time to be able to palpate these pulses. So again, we said that pulse rate normally is about 60 to 100, and what we would be doing is feeling that radial pulse and counting how many pulsations we feel in 1 minute. Apical pulse, on the other hand, is a little different way of evaluating how many beats the heart is making per minute. And this is when we take our stethoscope and we place it on the patient's chest, usually at the apex of the heart, and we listen for 1 full minute to the apical pulse. And when we listened, we'll come back to pulse deficit here in a second. I want to finish talking about apical pulse. The sound that the heart makes as it contracts is a lub-dub, lub-dub, lub-dub. So that's S1 followed by S2. And so when we hear the dub sound, that's our S2 sound, and that is when the heart is relaxing and filling. And this is also known as diastole. The lub sound that the heart makes when we're listening to an apical pulse is the S1 sound, and this is systole, or when the heart is contracting. And so when we're counting an apical pulse, each lub-dub is considered 1 beat. So as you're listening with your stethoscope, you hear lub-dub, that's 1, lub-dub, that's 2, lub-dub, that's 3, lub-dub, that's 4. And so that's how we count the apical pulse. So let's go back to what a pulse deficit is. To assess for a pulse deficit, one person assesses the peripheral pulse, while the other person assesses the apical pulse. So we have a patient, and we will have one nurse listening with her stethoscope on the apical pulse, and we would have another nurse feeling for the radial pulse, and they will both be measuring for the same minute on the same individual. And then they would compare the two rates. And the difference between the two is called the pulse deficit, which reflects the number of ineffective cardiac contractions in 1 minute, right? And so this occurs when the heart contracts inefficiently and does not transmit a pulse wave to the peripheral site. And so if you identify a pulse deficit in a patient, this will be something that you would want to report to the physician. What is happening during a pulse deficit is that the heart might beat, but what is being ejected from the left atrium is not sufficient enough to circulate through the body and cause a peripheral pulse, okay? So this would be maybe in the case of congestive heart failure, when we have a poor ejection fraction and there's not really enough blood being pumped out to actually cause a pulse in the peripheral parts of the body. So that's the definition of a pulse deficit. If you find a pulse deficit, you want to assess the patient for other signs and symptoms of decreased cardiac output. And, you know, we haven't talked a lot about cardiac output yet, but cardiac output is just how much the heart is pumping out, okay? That's the cardiac output. It makes sense that that's what it means. It's the output of the heart or of cardiac. And the patient may have dyspnea, and dyspnea is the patient's report of shortness of breath, okay? So we can say as nurses, oh, the patient is short of breath because I'm observing that the patient looks short of breath. But if the patient looks at you and says, I can't catch my breath, then they're having dyspnea. That's how we document that in the chart. The patient may complain of fatigue, or they may say, I feel tired, or I feel weak. They may say that they're having chest pain. They may say that they're feeling heart palpitations, which just means that they can kind of feel their heart pumping in their chest. And so any of these symptoms or complaints may be consistent with having a pulse deficit. So these are other things that you're going to be wanting to report to the physician as well. So we've talked about apical pulse. Let's take a second to talk about what a sinus arrhythmia is. This is one of the most common arrhythmias. This is really considered normal, sinus arrhythmia. What a sinus arrhythmia is a change in the heart rate during breathing. It's very common in children, and it's often found in young adults. It's not associated with any other cardiovascular symptoms or problems, okay? And so what happens in a sinus arrhythmia is the sinus node rate can change with inspiration, breathing in, and expiration, breathing out. And this is especially in younger people. So I would encourage you, if you have kids, go home tonight, put your stethoscope on them, and just listen to their heart while they breathe. And you'll notice that it sounds a little bit irregular. Their heart rate will be a little bit irregular while they're breathing, and that is considered normal. It's called a sinus arrhythmia. Their heart rate speeds up when they take a breath in, and their heart rate will kind of decrease a little bit when they breathe out. And this has to do with stimulation of the vagus nerve. Okay. So respirations. Let's talk a little bit about respirations. This is how many times the chest rises and falls in 1 minute. If we're going to be measuring this, it's best to measure respirations like the nurse in this photo here, where she's observing this individual with no shirt on, watching the chest rise and fall. But the other thing that you can do is when you are checking someone's pulse, you might lay your hand on their chest while you're looking at their pulse, and then you can kind of watch your hand rise and fall and count how many times your hand rises and falls in 1 minute while they think you're checking their pulse, but you're not, because you're really looking at their chest. See, that's the other thing about checking respirations. We don't necessarily want to tell someone that we're checking their respirations because then they become self-conscious about it. We kind of want to be checking respirations when they don't really know that that's what we're checking. You can see the kids here doing the Pledge of Allegiance because again, in kids, a lot of times it's easy to find what their breaths per minute are or their respiration rate is by watching how many times their belly rises and falls. Kids are belly breathers, or seeing how many times that their hand rises and falls. So checking respirations. We're going to talk about some of the abnormal findings. So bradypnea is respirations less than 12 per minute. So that means that they're not breathing enough breaths per minute. Less than 12 is considered abnormal. This could be due to a narcotic overdose. Somebody could be breathing less than 12 breaths per minute. Tachypnea is greater than 20 breaths per minute. So this is when the patient is rapidly breathing more than 20 breaths per minute. And this, again, could be for various reasons why they might become tachypnic. It's important for us to be able to identify that they are breathing fast and count how fast they're breathing in 1 minute. Apnea is a term that we use to describe respirations that will cease for several seconds. So we'll be watching a patient breathe. This is usually more of an end-of-life scenario, or in the case of sleep apnea. And we'll talk more about what sleep apnea is later, but some individuals actually stop breathing for a few seconds during sleep. And they may do it many, many, many times, all night long. They might have these apneic episodes during their sleep. And they tend to get very poor sleep as a result. Oftentimes they will end up developing high blood pressure as a result as well. And so apnea is something to be aware of. Agonal breathing is a kind of end-of-life breathing pattern. It's just really a brainstem reflex where there's periods of apnea, right, where they stop breathing for several seconds, followed by large gasps for air. And agonal breathing can be particularly upsetting to family members in a dying patient. And so as nurses, we want to try to use different medications that we may have available to help our patient relax better and try to deal with this symptom of agonal breathing if we can. And so another type of respirations are called Kussmaul respirations. And this is abnormally deep, regular, and fast breathing. So the difference between Kussmaul respirations and tachypnea is that not only are these fast, maybe more than 20 breaths per minute, but they're also very deep breaths. And we often see this type of breathing in patients that are having diabetic ketoacidosis, DKA, because they're blowing off carbon dioxide. And they will be breathing fast and deep. Those are Kussmaul respirations. And so we want, again, to memorize some of these abnormal vital sign terminology as well as the values. So a heart rate less than 60 is called bradycardia. A heart rate greater than 60 is called tachycardia. Respiration rate less than 12 is bradypnea. A respiration rate greater than 20 is tachypnea. And a temperature greater than or equal to 100.4 is usually considered a fever. When a patient's blood pressure is 130 to 139 diastolic over 80 to 89 systolic. We kind of are referring to that as a pre-hypertension. Pre-hypertension. So let's talk a little bit about blood pressure. As blood is pumped through the arteries, it creates a pressure within the wall of the arteries, right? And we said earlier, we talked about that pulsation of that blood, right? We can feel that in the peripheral pulses, okay? But when the heart contracts, there's an increased pressure, and this is called the systolic pressure, okay? As the heart contracts, this increased pressure is called the systolic pressure. So if you watch this animation for 1 second, what we're saying is when the heart pumps blood out, what's going to be happening within the vessels? The blood's going to be filling the vessels, and the pressure in the vessels is going to increase. And if you watch this animation, it kind of makes sense of what a systolic pressure is. Okay? In measuring blood pressure, we also have the diastolic blood pressure, and this is the bottom number. And this is when the heart is relaxing and filling. And so this decreased pressure is called the diastolic pressure. So again, if we kind of watch the animation here, it's when the heart is relaxing and filling. There's a decreased pressure happening in the vessels, right? Because the blood wasn't just pumped out. The heart's relaxing and filling. And this relaxed pressure is called the diastolic pressure. Knowing how to estimate the systolic blood pressure is always an important skill for a nurse. And so how do we do this? Well, the way that we do this is that we put a blood pressure cuff on our patient and we feel for the radial pulse, okay? And what we do then is while we're feeling for the radial pulse, we have maybe somebody else help us out here and pump up the blood pressure cuff while we're feeling for the radial pulse, okay? And as soon as we feel that radial pulse disappear, because the cuff has been inflated to the point where it is now inhibiting the flow of blood, that exact number on your dial is going to be your estimated systolic pressure. So I'll give you an example. Because we say that usually a normal systolic blood pressure is about 120 millimeters of mercury, if I put the blood pressure cuff on my patient and I feel for their pulse and I pump up the cuff until I hear their pulse cut out, in a normal healthy individual that's blood pressure is around 120 systolic, their pulse is going to cut out right as the dial gets to about 120. And then I'll know that their estimated systolic pressure is about 120 millimeters of mercury. This technique can be especially helpful in emergency situations when it's very difficult to get a reading on the systolic pressure because it is so low, okay? It's just always a good skill to be aware of, being able to estimate the systolic blood pressure. When we are measuring blood pressure, what we're listening for with our stethoscope are called Korotkoff sounds. And the onset of the Korotkoff sounds correlates with the systolic pressure. The fifth sound, there's 5 Korotkoff sounds. The fifth sound corresponds to the disappearance of the sound and correlates with the diastolic pressure. So I have a really good video here, and we're going to watch this video to see exactly what it looks like when you're checking a blood pressure and you're watching the dial move and you're listening for the Korotkoff sounds, and it will show you how to identify the systolic pressure and the diastolic pressure along with what you're hearing and seeing. So here's the thing I want to talk about really quick in terms of checking blood pressure. It is a really actually advanced skill. We don't think about it that way, checking a manual blood pressure, but it is, because there's so many different moving parts, right? You've got your motor skill of pumping up the cuff. You've got your stethoscope on the correct place and the brachial artery. You're listening with your stethoscope. You're watching the dial. And all these things are happening at once. And so this is not a skill that you will become really good at overnight, although some of you may already be really good at checking blood pressures. It takes time and practice. And so I would encourage you to practice on your family, practice on your aunties, your uncles, your significant other, your children, anybody that will let you, so that you can listen to lots of different blood pressures and really kind of get a sense for how to measure. And again, it takes time, so give yourself a little grace in that area until you train your ears and your eyes to be more efficient at identifying the correct values. The American Heart Association provides us with a really nice table that identifies all the different levels of blood pressure categories. And so normal blood pressure here is listed as a systolic less than 120 and a diastolic less than 80. Because remember, we said that a blood pressure of 120 over 80 and above was kind of considered that like pre-hypertension phase, right? And so here you can see elevated blood pressure. And if you look at different places, they will have different definitions. I like to use the American Heart Association's definitions because it's just always a good resource to go to for the most evidence-based information. You can see here how they are categorizing high blood pressure stage 1. They're saying that the systolic is between 130 and 139, and that the diastolic is between 80 and 89. And notice it says or. So that means that if you have a normal systolic blood pressure, but you have a diastolic pressure that is between 80 and 89, they're saying, well, we think you may be, still having stage 1 hypertension, even if your systolic is within the normal range. Stage 2, you can see here a systolic blood pressure of 140 or higher, or a diastolic pressure of 90 or higher. And then hypertensive crisis is when you have a systolic blood pressure that is higher than 180 and or a diastolic pressure of higher than 120. And a hypertensive crisis is just that. It is a medical emergency. I have seen patients out in public at health fairs and patients at doctors' offices who get a reading this high, and if there is a physician there and the doctor's office or any medical staff in this health fair, you will see them call 911 because a patient with a blood pressure that is this high is at risk for having a stroke. So let's take a second to talk about hypertensive crisis or high blood pressure. It occurs most often with a history of hypertension, when the patient maybe is non-compliant with taking their medications. It's a severe elevation in blood pressure, 180 over 120 or higher, and what's happening is we are worried about organ damage. We're worried about the kidneys, we're worried about the eyes, we're worried about the heart itself. So there's target organ damage that occurs when there is really high blood pressure. It's also known as malignant hypertension. It can be severe enough to cause visual changes, acute visual changes, blurred vision, double vision, neurologic changes. The patient can become confused, suffer from a stroke, or a hemorrhage, a brain bleed. And then, of course, we worry about organ damage. The kidneys are especially susceptible to organ damage in high blood pressure. And that's high blood pressure that is uncontrolled over a long period of time. Other signs and symptoms in a hypertensive crisis may include nausea, vomiting, a horrible headache, confusion. The patient could suffer a seizure and go into a coma. And so hypertensive crisis is a very serious problem. If you ever measure a blood pressure that falls within this category, they need clinical intervention. They need to be sent to the emergency room and they need to be evaluated. On the other hand, low blood pressure can be equally problematic. This we refer to as orthostatic hypotension, low blood pressure. This is when there is a decrease in the cardiac output. The brain is not getting enough blood, and this low blood pressure can cause lightheadedness, okay? So the patient may get lightheaded. They might have a syncopal episode where they kind of lose consciousness for a second. They might fall down from this. And so that puts our patients then at a risk for falling and getting injured in that case, right? So we want to be on the lookout for low blood pressure. Medications can drop our patient's blood pressure, and any antihypertensive medication, really any class, can cause low blood pressure, right? So the idea of giving our patients blood pressure medication is to control their blood pressure from being too high. On the other hand, we can give them a blood pressure medication that can cause it to go too low. Metoprolol is an example of a beta blocker. Lisinopril is an example of an ACE inhibitor. Cardura is an example of an alpha blocker, and Norvasc is an example of a calcium channel blocker. Any of these can cause low blood pressure. Vasodilators like nitroglycerin can cause low blood pressure. So if you have a patient who's suffering from angina or chest pain, and they take that little nitro pill sublingually underneath their tongue, we want to make sure that they're sitting down. We want to make sure that they don't stand up quickly because they could have an episode of hypotension where they might get dizzy and fall. Diuretics like Lasix can also cause hypotension because if we are diuresing or urinating a lot of fluids out of our body, we could have a drop in our blood pressure. And so other things that might cause this are being on bed rest for a prolonged period of time. If we have a patient that's bleeding internally, they're losing blood volume, that could cause their blood pressure to drop. And also dehydration, so vomiting and diarrhea episodes can cause this to happen as well. So we always want to make sure that when our patient has been lying down for a long time, we want to get them up slowly. We want to make sure that if our patient has been vomiting or been having problem with diarrhea, we know that they're losing a lot of fluids. We want to try to replace those fluids. What do we do if this happens? Let's say you're going to get the patient up for a walk and you sit them on the edge of the bed, you dangle their feet, you have them stand, they say, oh, I feel dizzy and unstable. You want them to sit back down, and this usually will resolve when the patient returns to a sitting or a lying down position, okay? So remember, we want to dangle their feet before we stand them up. We want to get them up slowly. Sometimes wearing TED hose can help with this, and we want to have them increase their fluid intake as well. We always want to make sure that we've reviewed their medications. Are there any new medications that they're taking? And we want to always make sure that they're taking the correct dose, because if they're not taking the correct dose, that could be very much the reason why they're having orthostatic hypotension. I think that it's important for us in this very last section to just talk about how we measure orthostatic blood pressures, okay? Orthostatic blood pressures are also called postural blood pressures. So you may have an order in the chart, or you may have a physician tell you verbally to go get postural blood pressures or go check orthostatic blood pressure. And so what you want to do in this case is measure the patient's blood pressure in 3 different positions. You want to measure the patient's blood pressure lying down in their bed. You want to record that. You want to have the patient sit up into a sitting position. You want to measure their blood pressure again, and you want to record that. And then if it's safe, you want to have the patient stand up, and you want to check their blood pressure a 3rd time, and you want to record that blood pressure. And then you report those blood pressures back to the physician. Again, it's always important to know what their baseline blood pressure was too. And we want to make sure that if from lying to a standing position, if their systolic blood pressure drops more than 20 millimeters of mercury, then we have a significant finding. We're going to, if a doctor orders for us to check these, we're going to report these values regardless of our findings. If the doctor asks for something, we're going to report all of the values to the physician. I just want you to know that generally speaking, if we see a drop in blood pressure from lying to standing of 20 millimeters of mercury or more, it's considered significant. The other thing that can happen is if the heart rate increases by 20 beats per minute or the patient becomes tachycardic, this is also significant, all right? So from a lying to a standing position, they become tachycardic, their heart rate shoots up. This is considered a significant finding. So that is all I have for you today. Thank you for your attention, and please make sure you study these slides as that they will be very important for your quiz. Until next time, aloha.